To this now, the Gauteng Health Department has confirmed that it has started to investigate allegations of negligence at the Helen Joseph Hospital in Johannesburg. A former broadcaster, Tom London, who was admitted to the hospital, made the allegations in a video post on social media. He claims to have experienced neglect and rude behavior from the staff, including doctors. Gauteng Health Department spokesperson Motalatale Modiba joins us now in the studio to unpack this situation. Thank you so much for your time. Of course, this video went viral. I'm more interested in how South Africans reacted to this video. What the Tom London video showed is that a lot of South Africans have experienced similar situations at state hospitals, mainly in Gauteng, not just Helen Joseph Hospital. We know of stories from Baragwanath to Charlotte Maxeke. Just talk to us firstly, just about your reaction to that video and just the dilapidated infrastructure that we saw in the video, the way in which the sentiment of doctors not caring and behaving in an inhumane manner, not only to Tom London, but also to some patients who were sharing the same ward.
Well, Onati, I suppose the issue around the behavior would be inexcusable given the standards that we've committed ourselves to insofar as how we provide services to communities. So there's no excuse about that. And I think it's part of the reason why, as a department, we have embarked on a campaign called the I Serve with a Smile campaign. It's coming out of the realization that we might have the best clinical services that we're providing insofar as the clinical care part of things is concerned. But the bigger issue that the public seems to be raising is the issue around the attitude and the patient, what we call the patient experience of care. That yes, you've given me a Panado, but how did you give it to me? You know, are you giving it to me in a way that recognizes me, that I'm here as a patient to receive care, in a way that is dignified and so forth. So I think that is something that we obviously are concerned about, and that's why we have embarked on this particular program. Well, I suppose you'd say, given this outcome or this outcry, it shows that we still have a long way to go insofar as entrenching this culture within the service.
I would say so, because just staying with the Helen Joseph Hospital, we've heard horror stories. I mean, I remember not too long ago, a mother talking about how her daughter was not seen and treated for 24 hours in the hospital, and she had to, in fact, alert doctors in the emergency room 24 hours that her daughter had actually died in that waiting room in the wheelchair. So we've heard horrific stories about the treatment of patients. So it may not be all doctors. We of course can say that. But what is troubling is that patients all sharing the same stories. A patient will come to the hospital at 5 a.m. knowing that of course the clinic opens at 7 a.m. will only be seen by a doctor around 10 a.m., will only get their medication at around 2 p.m. So it's these ongoing stories that we are hearing consistently, and the fact that the hospital has not had a CEO for a number of years now. So it does also speak to systemic issues from a leadership scale. So it is concerning for one to see that the MEC has also responded to what Tom London has had to say in his video, and saying that essentially she has spoken to clinicians saying that she is satisfied that adequate clinical care was given to manage his condition. It's not only Tom London we're speaking of many South Africans. I mean, what is your response to that?
I think it comes back to the point that I raised, to say, when it comes to the issue around the clinical care, and even Tom himself confesses that clinically he's satisfied with the type of care that he was given the condition that he came with. Remember, he spent 2 weeks in our facility, and he says, I'm quite happy with the clinical care. What I was not happy with is the attitude, the manner in which I was treated and so forth. And I think that is something that we're working on. We've got a program to intervene. Even now, we're meeting with the entire team at Helen Joseph to debrief, to take them through a particular process. The I Serve with a Smile campaign is not just a campaign. It's a campaign where you take through the participants through communication skills in terms of learning how to communicate. You might be a technically astute clinicians and so forth, but there's a level of care that requires you to be able to communicate, share information with me in a particular way. In the health system, we've adopted what is called the IDED model of communication, which means I must acknowledge you as a patient as you come in to say, I know you, and I must introduce myself and all of those things. So it talks to the empathy element of service for us to be able to render care in a way that says we do care. From an infrastructure point of view, we are working, we've got a program that is currently being rolled out. In fact, at the very same Helen Joseph, if you recall, 3 months ago, we opened a revamped accident emergency department, which previously was a source of concern. We've invested in that. It's now a new facility. It's a revamped. So we're working section by section in terms of working on some of the infrastructure issues that were also raised.
The issue of the CEO, the hospital itself not having a CEO for a number of years, when will that be addressed? I'm asking this question because whilst you may be introducing, campaigns of empathy for doctors, there has to be some form of consistency throughout the hospital, because in your assertion, of course, relaying what Tom London said and spending two weeks at the hospital, he spent 3 days in the emergency unit. Some people have spent 2 weeks in the emergency unit, sleeping at the unit instead of being transported to the ward. So there is that lack of consistency. He's also acknowledged that, of course, he's received good care in that clinical stage, but there was one toilet for all the patients that come to that particular emergency unit, where he also could not, reach that toilet. And it does beg the question then, does this not speak to greater systemic issues that a CEO, for one, from a leadership perspective, would be able to close those gaps?
I think, let me first correct, in the emergency department, there's not one toilet. It's new, it's refurbished. The concern that he has is water aid, where he would have spent most of the time, where there's a need to do maintenance work on part of the ablution facility and so forth. And that has been acknowledged, it's been attended to. The issue of the CEO, as we speak now, interviews are sitting in the following week. There's been a process. There was an acting CEO. Even now, there's currently an acting CEO, because we can never fully leave a facility without the CEO. But that process has been fast-tracked. We had to restart the process after we could not find a suitable candidate. We went again. So fortunately, hopefully now in this current process, where I'm saying next week, the interviews are sitting for the CEO for Helen Joseph. So hopefully out of that process, where we will have someone who will be able to lead, because you are quite right that the issue around the leadership at an institution level is also quite significant and it's important.
And another thing about infrastructure, I want you to just bring us up to speed in terms of where are we now in terms of much needed infrastructure. I take your point in terms of the new emergency, clinic that was recently just opened, but the MEC is saying and making reference of dilapidated infrastructure has no material effect on the treatment. Is some of the things that patients have been raising to say, they can't bath, for instance. They can't access much needed ablution facilities is another one. Those do have a direct bearing on somebody's, treatment and also well-being.
I think the MEC was very specific when she was communicating around that. I was there yesterday when she said that it was in specific reference to the specific case that we are dealing with. Because we went on site, we saw what is there. The infrastructure there is habitable, it's usable. It might not be at a standard that maybe at a morning site, if I go there, I'm used to this particular standard. But it's not the type of infrastructure that you say it's not habitable. It is habitable, it is usable. The standard issue is something that we can debate and we can work around and so forth. But there is a maintenance and infrastructure refurbishment program that is currently underway. And that's why I was able to point to a facility has been opened, and it's not only for Helen Joseph. The Bara ICU, the Dr. Josh Mukari ICU, Discoverers, we've done work in those particular facilities. Currently, as we speak, that program is being rolled out, of course, within a limited sort of budget, but there is an acknowledgement that we need to maintain but also refurbish our infrastructure to keep it at a level where it's acceptable when for both, not just for patients, but also for our own employees.
What is your response as a department, to criticism that the status of hospitals in Gauteng are basically showing us a sign that this system will not be able to handle the national health insurance. Just your comments around if we are seeing the level of service at this level at state hospitals in the province specifically, how then will national government be able to implement the national health insurance?
I think we need to be careful, especially when we're trying to look at this type of incidents and just oppose them against the national health insurance. First, understanding what the national health insurance is. It's a funding mechanism. We have said, and the minister is on record saying this, that the system as it is will be implemented in particular phases. Part of the phases now would be to deal with your OHS issues and the other state of readiness insofar as the infrastructure is concerned. And remember that with the NHI, when it's implemented, it's not just public health facilities that are going to be accessible. It means your Londons of this world who says, I went there because I didn't even have money to afford to go to the facility that is next door to me. He will be able to access that. But I think it's a wrong argument to try and use that to discredit the NHI, especially if you look at what the NHI is, which is a funding model, and we still have a long way to go insofar as the actual implementation where you and I will be able to tangibly access the benefits of the NHI, something that we're working towards. And I think for me, it actually demonstrates a point why you actually need to go towards that direction, so that the public healthcare system, which is currently dealing with 80% of the load, with 20% of the budget, you can then have what you call equitable redistribution of the resources that are available, not to cater for the few who can afford, but to then be able to say, how do we broaden the access to the system to allow those that cannot afford to also be able to have access to the quality care that we need. So for me, actually, this is actually even a stronger argument why we need to work jointly to fast-track an introduction of that kind of a system that will bring equity into the system.
I think what a lot of people want to see is some form of change, and change fast, given the fact that the current system is failing many South Africans. But thank you so much for your time, and of course we'll touch base with you in as far as those investigations are concerned. We know you've started the investigations into this specific hospital, and of course we'll continue to follow through with you. But thank you so much for your time.